Thanks to all the audience who follows our broadcast. We are live on the second day of the 2020 International Web-Based Neurosurgery Congress. Remember, we are streaming on YouTube Live too. Continuing with our schedule for today, preceded by excellent speakers, we have the honor of having Dr. Jacques Morcos. Dr. Morcos is a well-known neurosurgeon at the Jackson Memorial Hospital. He is co-chairman of the Department of Neurological Surgery, professor of clinical neurosurgery and otolaryngology, director of skull-base and endoscopic surgery and cerebrovascular surgery programs. Today at the IWBNC, Dr. Morcos is going to share his lecture, Bypass Surgery for Aneurysms and Moyamoya, a necessary skill, rationale, techniques, and results. Please type your questions in the questions and answers section. We will read them after the end of Dr. Morcos' intervention. Welcome, Dr. Morcos, and thank you. It's all yours.
Thank you very much for inviting me to be part of IWBNC. It's a pleasure to meet everybody from around the world and to talk about one of my favorite topics, really, which is bypass surgery for aneurysms, ischemia, and Moyamoya disease. It is a very long topic, and I'm going to have lots of material, and I do want to try to stick to the time. So if I find that I'm running out of time, I might skip to the conclusion, but I really don't want to make sure I give you everything I can give you about this topic. So bypass surgery comes in two varieties, and I can see from the program that you have already heard Fadi Charbel yesterday, and the concept of flow replacement for aneurysms and tumors and flow augmentation for Moyamoya and atherosclerotic ischemia. So the outline of my talk will be this: Moyamoya, then cerebral ischemia, and then aneurysms. Disclosures are irrelevant to this talk. Let's start with Moyamoya. Moyamoya in pediatric patients first. As you know, there is something called Moyamoya syndrome and something called Moyamoya disease, and these are the causes of Moyamoya syndrome. You can see them on this list in children. And when do you treat a child with Moyamoya with a bypass? Well, if they've had a hemorrhage, or if they have symptomatic ischemia or TIAs, cognitive impairment, decreased cerebral blood flow, or cerebrovascular reserve, and possibly asymptomatic cases that have an IV sign on an MRI, because 50% of them will progress within 5 years. Moyamoya in adults, similar indications. And what are the methods to treat with a bypass? You have this direct bypasses over here, STA-MCA or STA-ACA. And you have the list of indirect bypasses. It's like an alphabet soup. EDAS, whether you use a muscle, the dura, many possibilities. Or you can do both, the so-called combined, direct and indirect. So let's start with an example. 32-year-old nurse. She actually is a neurology nurse in a stroke unit, comes in with arm heaviness, infarction. Here is her very narrow carotid artery in the neck. Here is the typical Moyamoya changes with an early Suzuki grade. You can see that here. And attempt at collateral formation from the posterior circulation through the pericallosal system. And this is her external carotid injection. And we then have to do some physiology on her. So I like to do vasomotor reactivity with transcranial Doppler. It is very low in her, 27% in the right hemisphere, 32% in the left hemisphere. Then I do SPECT scan with Diamox, but more recently we've been doing CT perfusion or MRI perfusion, and it was also diminished in her. So here is the surgery. It's a left STA-MCA. We trace the STA arteries, we dissect them, and I'll talk later about how I'm doing it more recently, but you can do a single barrel or a double barrel bypass. And here we are measuring with the flow meter the recipient arteries, the frontal M4 and the temporal M4. The number in this case is 3 cc per minute. And then you cut the STA and you measure the cut flow, again, following the concept of Fadi Charbel, who, if you've heard his lecture yesterday, I am sure he would have spoken about this. This is a so-called cut flow, in this case, 60 cc per minute. Then I do the anastomosis. Whenever I can, I like to do the anastomosis in a continuous running manner, but certainly you can do it interrupted, and many people do it interrupted. It doesn't really matter. It depends on your preference. It is important to fish mouth the STA so you don't create stenosis. Here is the bypass completed, and I measure the flow after I complete the bypass. Remember, the cut flow was 60, and now it's 64 cc per minute. It means the cut flow index is even more than 100%. It tells us that this patient really needed the bypass. And that's, again, the concept of CFI, cut flow index. You can measure the flow one direction and then the other direction, and these are the numbers at the bottom. And there is a CTA after surgery. And then a few weeks later, I perform the bypass on the other side. And you can see the craniotomy for the bypass. And that's one side, and that's the other side. Very nice patent bypasses. How about atherosclerotic ischemia? Moving on from Moyamoya. Well, we need to know the physiology. We need to know what the COS study has shown, the carotid occlusion surgery study many years ago, because this is the crux of the matter in doing bypasses for cerebral ischemia. So a little bit of physiology. I encourage the students among you or the young trainees to go back to 1961 and pull this paper to try to understand what happens when you are hypotensive. What happens to your cerebral blood flow? It drops, but oxygen extraction fraction, OEF, goes up so that the product of both maintains CMRO2. That's normal physiologic adaptation. Here is a formula that explains why this happens. And if CMRO2 were to drop, with CBF dropping, OEF would stay the same. And this is carrying oxygen carrying capacity. And of course, that changes with temperature, which is why hypothermia, of course, is used for treatment. The first bypass study of 1985 showed that bypass was not helpful in the case of carotid occlusion compared to best medical therapy. But back then, that study had not looked at the physiology of patients. And the physiology is very important. So to remind you, what is stage 1 autoregulatory, stage 1 ischemia is autoregulatory vasodilation. You can see on the graph here what happens. CBV goes up as you vasodilate. CBF stays the same. OEF stays the same. Cerebrovascular resistance goes down. And the way you study this is you can look at CBV, mean transit time, or do paired CBF measurements. Then stage 2 hemodynamic failure is when OEF starts changing. You can see that right here. OEF goes up, and you can evaluate the results right here. The COS study came and tried to include patients based on their OEF in stage 2. Without going into the details of the study, if you are not familiar with it, it was stopped prematurely because the surgical group did not do better than the medical group. These were the actual stroke risks at 2 years, 22.7% medical group, 21% surgical group. Why did the trial fail? Because the projected numbers was 40% of strokes at 2 years in the medical group, and it was half of that. And it's been ascribed to many reasons, but particularly to the use of statins. So the conclusion was bypass doesn't help. I was part of a group with Sepi Amin Hanjani, Barker, Charbel, and others that tried to rebut this study and say why we had some criticisms about it. And I encourage you to read those papers to try to understand it. I want to draw a parallel between the COS study and the SAMPRESS study. The SAMPRESS study is intracranial stenting for atherosclerosis. It also failed, but I want to draw your attention, those two studies failed for different reasons. You can see the Kaplan-Meier of the COS study. The Kaplan-Meier curves of the medical group and surgical group are beginning to cross. In the SAMPRESS study, they were always parallel. They never crossed. What does that mean? It means in the COS study, it was a surgical morbidity that created the failure of the trial. But SAMPRESS study, not only the endovascular morbidity, but there was lack of effectiveness. Nobody is saying in the COS study that bypass does not help. The conclusion is the OEF will improve when you do a bypass. The patency rate is great, but if you can do it at better than 15%, it might have had a positive result. So the Kaplan-Meiers, had we extrapolated them, perhaps after 5 years, the bypass group would have made a difference. We will never know because, of course, statistically, the bypass study the COS study was discontinued. When they then published the results of the surgical group, Bob Grubb, who's a co-PI with Bill Powers, they analyzed the surgical group of the COS study. I want to draw your attention, the occlusion time to do the bypass, I feel is very long. 45 minutes occlusion time to do the bypass among the hands of what should be experienced surgeons. 45 minutes in the group that did not have a stroke, 55 minutes in the group that did have a stroke. However, there was no statistical difference. But I do want to draw your attention that these are very long times for an STA MCA bypass. It should be about 20 minutes, 25 minutes, 30 minutes, but not that long. I'm not suggesting that's a reason why it failed, but I'm suggesting that that's a consideration to understand. The details of those 19 strokes in the surgical group were here. It was not very clear if even a small stroke or a large stroke occurred. We don't have the full details of those MRIs. Excuse me, I'm giving a talk. Close the door, close the door. No, excuse me, bye. So I'm sorry for the interruption. Somebody opened my door. Stroke risk beyond 2 days post-op were 9% in the surgical group and 22% in the medical group. That's a 2.5-fold benefit from the surgery in spite of the failure. As you know, in China, there is a CMOS, which is essentially a Chinese COS study. We don't have the results because in China, they realize that the final chapter has not been written about whether bypass helps or does not help in cerebral ischemia. I'll give you an example why many of us feel it does help. This is a typical case, watershed infarction right here in a 76-year-old man who's having TIAs, multiple TIAs every day. Here is his carotid artery occlusion, and the other side is okay. And here is a SPECT scan showing that he has misery perfusion with Diamox, and his vasomotor reactivity is very poor, 19%. That's very low compared to his normal hemisphere, which is 55%. By the way, you do these with transcranial Doppler with CO2 manipulation. So I did a bypass. Here is a STA MCA bypass. Here is post-ops CTA. This man who was having multiple TIAs every day did not have a single TIA for 10 years after this surgery and died of a heart attack at age 86. I'd like to thank my residents and my partner for looking helping me look up my series which I had looked up from 2005 to 2016, and we are updating it currently because I do have many more cases since 2016, but this study looked at 105 cases of Moyamoya and atherosclerotic ischemia. Luckily, I work with excellent stroke neurologists who realize that after the costs, that the devil is in the detail, and my referral actually numbers have gone up after the costs, not gone down, because of the excellent group of stroke neurologists I work with. And of course, you have to select the patients appropriately. So I'm gonna skip some of the slides that have some of the demographics, but I do want to bring your attention to some of the complications. This is in the Moyamoya disease group. There were 3 symptomatic ICH and 4 symptomatic infarctions. And in the atherosclerotic group, 2 ICH, 2 infarctions. Then I was very interested in trying to duplicate what Charbel may have shown you. I don't know, I didn't listen to his talk yesterday, but he's published extensively on this, the intra-op flow data. So I measured flow, as I showed you. In Moyamoya diseases, there was no difference based on the cut flow index between those grafts that occluded later on and the grafts that stayed patent. The grafts that occluded later on were 10% up to 3 days later. And most of the time, 3/4 of the time, the occlusion of the graft was asymptomatic. What does that mean? These are not technical failures. These are the evolution of the normal physiology and the indirect collateral formation that often forms. And then the bypass is not needed. The direct bypass is not needed and slowly closes off. Graft survival over time. Here is, again, Kaplan-Meier of my Moyamoya data. Intra-op flow data in the atherosclerotic group, almost identical number, 10% occluded later on. Of the 105 cases we studied, only 1 out of 105, I was unable to achieve a patent bypass during the surgery. And all of the graft occlusions that occurred delayed in atherosclerotic group, all of them were asymptomatic. I lumped together the atherosclerotic group and Moyamoya group, and I could not see a correlation or a predictability from cut flow index in predicting who will occlude and who will not occlude. So that was interesting piece of information. What's more important, however, is not the flow numbers, is the clinical outcomes. Did I help the patients doing the bypasses on them? Yes, I did, because this is pre-op modified Rankin score. This is post-op modified Rankin score in both Moyamoya and cerebral ischemia. And you can see it in a different format. Patients are getting better after surgery in both groups, Moyamoya and atherosclerotic group. And if you look at it in a pie chart format, 85 to 90% of both groups have improved. So that justifies the use of direct bypass in Moyamoya patients and in select, and I repeat, I don't mean any patient with carotid occlusion. They need to meet the stage 2 hemodynamic insufficiency to have the bypass done. This meta-analysis a couple of years ago looked at Moyamoya disease and whether you should do direct or indirect bypass. I'm a strong believer that direct bypass in the adults is better, and this meta-analysis shows it. Surgery is better than conservative in Moyamoya. Surgery is better than conservative treatment in future stroke events in hemorrhagic Moyamoya or in ischemic Moyamoya. Direct is better than indirect bypass in decreasing future stroke events. People often ask perioperative complications. There is a trend for more complications indirect bypass, it is not statistically significant in this meta-analysis. And of course, direct bypass is better than indirect in achieving better angiographic outcomes. But my current preferred technique in doing a direct bypass for ischemia or moyamoya is a single donor, a single STA, double recipient. You can call it SDDR, single donor, double recipient. I will show you a video of this in a case of moyamoya disease. The details of the case are not important. You can see classic puff of smoke appearance. Here is the incision. You try to go for just one artery, one of the branches of the STA. You can see, I like to use the Colorado needle. Here is the Glow 800, which is ICG. The STA cut flow in this case was 50 cc per minute after I cut the STA. And here we are cutting the muscle in a T-shaped format. Then doing the craniotomy, and I want both recipients. So I want to do double bypass because it is moyamoya, and as you know, moyamoya tend to have isolated circulation oftentimes in the frontal and temporal lobe. So what do? I measure the flow. In this case, it's 2 cc per minute here. It's 4 cc per minute in this lobe, and that gives me my baseline flow measurements. Then we bring in the STA. This is a Glow 8, the ICG. You can see it in black and white down here and in color up here. And then we're going to do the anastomosis. We can talk a lot. I don't have too much time to talk about actual technique, but briefly, I only anchor the stitch. I call it at 12 o'clock. You will see in a second, we're going to put temporary clipping. I'm going to use a disposable arteriotomy knife to cut it. And then we are going to color the edges, and you place the 12 o'clock stitch. Now, if you've seen other lectures by other surgeons, each one of us does it differently. I like to not anchor the 6 o'clock position. Why? Because it allows me to see the edges. If I am trying to teach, or I am working with a resident or a fellow, or both of us are operating, often I do interrupted stitches, so there is more opportunity for stitching. So here in this case, we're doing multiple interrupted. You do one side, then you do the other side. You relieve the clips, you put a little Surgicel on the arteriotomy. So this is one bypass done. I measure the flow. You see, you can now measure the flow in the second recipient and decide if you need the second bypass. So I measured the flow. It was 43 cc per minute. Remember that number. Then I said, well, this recipient here did not increase the flow. So I proceeded to do a second bypass side to side from this STA to that second recipient. So that's how I decide if a second bypass is done. Side to side is a little harder. I don't recommend for the young people who haven't done too many bypasses to start doing this. You need to have a little bit of experience to be able to do a side to side, because of course, if you have a technical problem, you ruined this bypass that's already done, and you don't want to do that. I prefer that you do 2 branches of the STA if you're still not comfortable doing this technique. But the reason to do it is to save the other STA for the future, to avoid necrosis of the skin and so forth. So here we are doing a side to side. Of course, when you do a side to side, you have to do the back wall in an endoluminal running technique. So you have to take the stitch behind and then start running from the inside. So if you're right-handed, you go inside on the right with the right hand, outside on the left, inside on the right, outside on the left, and you run it. So if you're left-handed, it's the opposite. And then when I reach here, I will suture and make sure the knot is outside. You don't want the knot to stay inside, or you might create thrombosis. And then the front wall is easy. Then you remove your clips and you remeasure all the flows. And we're going to do the flow and you will see the flow is 60 cc per minute. That's higher than the cut flow of 50 cc per minute. Why? Because I did a double bypass. So then that's a way to give the brain more perfusion. So that's my current preferred way of doing these ischemia or bypass for Moyamoya or ischemia bypass. These are the final numbers. 60 cc, you create a tunnel in the bone, and we're going to do a post-op angiogram. It's a very nice, you can see double anastomosis, one here and one here. You can probably see it on lateral as well. One here and one here. You can see both through the single vessel. Uncommon bypasses, I'm going to show you some unusual ones I had to do. First, we're not going to talk too much about it, but posterior circulation ischemia, I call it the orphan disease of cerebrovascular neurology and cerebrovascular neurosurgery. Many patients are not being treated because honestly, very few people still know how to do a posterior circulation bypass. I will only show you one example because of time. I did occipital to pica bypass on this 69-year-old with multiple, look, he has almost no posterior circulation, multiple TIAs of the posterior circulation. You use the occipital artery, in this case, to go to the pica through a kind of a far lateral or suboccipital approach to go to the pica. I don't really have time to show all the details, but here is the pica. Here are the lower cranial nerves. You need to make sure you look for the perforators, and then you take the occipital artery and like you do it, it's a little deeper, but look how much space you have. You have a lot of space, even though it's deeper than the STA, MCA. Be very careful about the perforators going to the brainstem, and that will dictate how much you can move the telovelar, the telovelar segment of the pica, P4. That's where you want to do the bypass. I am measuring how much occipital artery I need. Here is the occipital artery. I'm measuring how much I need to cut. So we cut it, and we're going to take it down, and we're going to do exactly the same thing. And here is the bypass, end to side. Nothing new, exactly like I showed you on the other side. By the way, you will notice I like very much to use curved needle holders because it gives you an extra degree of freedom with your wrist. And we're going to do one side. Usually you do the back side, which is more difficult. The back side first, then you do the front side. And you see, by using the curved, you can put a needle backwards. You don't have to always go forehand with your needle holder. You can go 360 degree. It gives you infinite degrees of freedom with a curved needle holder. And by the end, I'm going to skip through. You measure the flow. Bypass looks excellent. And here is the bypass. Post-op angiogram, very nice anastomosis, and the patient's symptoms completely disappeared. You can see the basilar filling through this bypass. A bonnet bypass, very unusual to do. When you don't have STA, I'm going to very quickly go through this case. They are extremely rare. You don't have an STA on the side that you have the symptoms. So what do you do? This is the STA of the other side. So I used a vein to go from one STA across to the other side craniotomy. This is the second time I've had to use this rare technique. Here, this is a side where the STA is very poor, only 7 cc per minute. I thought I'll try, but that's terrible flow. You cannot use it because of the occluded common carotid. You see, you do a side-to-side incision. This is a good STA of the opposite side. Where do you do your arteriotomy? You do it right here at the bifurcation of the STA. Here is a saphenous vein. I'm going to skip through quickly. And here is you mark and then you make your arteriotomy, you measure the flow. Let's see what the flow says, 77 cc per minute. So as we should not say STA bypass is a low flow bypass. 77 cc per minute is a huge amount of flow. It should be called low capacitance. So not low flow. Everybody keeps talking about low flow, high flow. It's not accurate. STA can be high flow. In my data I showed you earlier, it can be up to 120 cc and actually 160 cc in one case. So I do the anastomosis, then show you the, oops, I'm sorry, it jumped to the next video. I'm sorry, let me go back and just show you the final result. Right here, you see I drilled into the bone a channel for the vein, and then I enter the sylvian fissure on the left side. And I'm not going to show you this anastomosis, but here we are doing the vein to the MCA, and there is the finalized result, relieving this. 53 cc per minute it delivered, and that is a completed bypass. Another unusual use of a bypass is occipital artery to angular artery bypass. When you don't have STA, but you have a good occipital artery, you can use the occipital artery from the back, but you cannot go all the way to the front.
To a 50-year-old female with
this is narrated, but let me,
which was previously approached through a
this is my fellow narrating it.
And followed by
I am going to show you briefly the occipital. Here is the occipital artery. There is no STA due to previous tumor resection and radiation therapy. Here we are mapping the occipital artery.
6 cm goal of exposing the distal fissure.
There is a craniotomy on the distal fissure, and there is the occipital artery. You can see it can reach.
The vessel was then injected with heparinized saline
all the way.
Atrophying the bone this is an important step that ensures when the occipital artery is measured to proximal is placed first in this case to anchor both.
And I'm not going to show the anastomosis, it's all the same, but I want to show the final result. You see, here is the final view, occipital artery to angular artery bypass. So remember, if you have an occipital artery but no STA, you can do it, but you can reach, the most you can reach is the angular artery. And here I'm creating a channel in the skull, like I did for the vein. And look at the nice post-op angiogram.
Angiogram later confirmed patency of the bypass.
There is the bypass. You see where you go to the angular artery through the occipital artery. Conclusions for the ischemia part of the talk, and I'm going to have to really go fast for the aneurysm part of the talk, is that it's very effective in reducing stroke risks in symptomatic Moyamoya disease and very select atherosclerotic occlusive disease patients. I was able to keep a bypass patent in the OR 104 out of 105 times. So it has a high immediate patency rates. When they occlude later, they're usually asymptomatic. Intra-op flow measurements are very important in guiding how you do your bypass, double barrel, single barrel, which artery to use. But it's a complicated concept, but it's very useful. I cannot tell you anything about indirect bypasses because I don't use it. I don't think it should be used in adults since we can do direct bypasses in almost everybody. It is a great mistake to abandon bypass surgery for ischemia and Moyamoya, particularly since the cost study was published. You have to analyze in detail, if you're not familiar with it, what were the weaknesses of the study. Even though it is a very important study, it had weaknesses that I don't have time to go over today. They have to do with randomization and external validity versus internal validity. And I encourage you to, if you do bypass surgery, to enroll your patients in a registry with neuropsych testing pre-op and post-op, because besides stroke prevention, patients who are hypoperfused and you do a bypass, their cognition gets better. All of us who do this know this. So now a brief pause to go on to bypass for aneurysms. I will start by saying my message, then I will go over the details. With aneurysms, it is absolutely true that this bypass surgery is still an option. And I think Rokua Tanikawa, I think, is giving 2 lectures after me. And I'm not sure if it's going to cover bypass surgery, but certainly we are of the same philosophy that bypass surgery is very important for aneurysms. It is the only treatment for many complex aneurysms. And yes, of course, flow diverting devices are very important, but they can be abused by, for many reasons. We're not going to go into that, but there are many reasons why flow diverting devices are being abused, are being used off-label, distal circulation. Of course, endovascular is very important. It is continuously advancing, but I will show you cases that cannot be done endovascularly. So let's go over this. Let's first start with the basic review of microsurgical instrumentation. I've written a chapter with my resident a few years ago in this very nice book by Pascal Jabour. And it's chapter 3, and some of the slides I'm going to show you how you sit, how you hold the mouthpiece in your mouth, how you analyze your instruments. You have to remember your instruments are levers. Do you use a needle holder or do you use a forceps to suture a 10-0? I don't have time to go over it, but there are very important details that have to do with mechanical advantage, with how your hands are used, how your wrist turns. You're welcome to read the chapter and go over those details. The sutures we use normally are 10-0 sutures, ethylon, with a certain degree of needle curvature, 3/8 curvature, not 1/2. 3/8 is better, particularly for STA-MCA bypass. If you use a vein graft, use an 8/0. If you use a radial artery, use a 9/0. At least that's what I do. The geometry is very important. This is from a different chapter. I've written another book. When you fish mouth and you analyze the geometry of an end to side, when you fish mouth, you increase the cross-sectional area 4 times compared to this. This anastomosis is 4 times bigger than this one because it's a square law. That's why you fish mouth in general when you do these end to side. When you do end to end, you slant your cut. So again, for the same reason, to increase the cross-sectional area. And very importantly, when you do side to side, you have to do a running technique. So those are the 3 geometries: end to side, end to end, side to side. You use side to side in all kinds of aneurysms: pica to pica, M2 to M2, A3 to A3, PCA to SCA. When I do a side to side, I like to do it this way. I like to do 1:30 to 10:30, I call it, not 12 to 12 o'clock or 3 o'clock to 9 o'clock, because this is the best way, best compromise of visualization and apposition. When I categorize bypasses, I fit them in one of 5 cells based on number of anastomoses and based on whether you're using an intracranial donor, a local extracranial donor like STA or occipital artery, or a distant extracranial donor. If you follow my scheme of thinking about this, you can fit any bypass you invent today. You can, I promise you, it can fit in one of these 5 cells. So then I'm going to, now the rest of the talk, give you examples of these 5 cells. No graft or graft, these are the 5 cells. I'm going to go quick because there's lots of material. Let's start with the first cell, this one, local extracranial, with anterior circulation examples. I'll give you an example of a double barrel. I'm going to skip some details. Double barrel bypass with an STA on this patient with sickle cell. Please notice one thing. Many of you may look at this STA and say, that is so small, you cannot use these STAs for a bypass. And this is to show you that you cannot judge based on an angiogram. You have to dissect the STA, liberate it from the skin, and then measure the flow. Here is the aneurysm. It's a 2 outflow from this distal MCA aneurysm. You cannot treat this properly endovascularly, that distally, with a double vessel, 2 arteries coming out of it. The radial artery, we tried to do an Allen test. She failed, so you cannot take her radial artery. So I proceeded, I'm not going to show you the video. I proceeded with a double barrel bypass, but look at those STAs, they're excellent. Once you dissect them, they look much better than what on the angiogram suggested. Here is the ugly aneurysm she has, and that's after finishing a double barrel bypass. You can see one side and the 2 side to the 2 branches, and I trapped the aneurysm. And she did beautifully. I have many, many years of follow-up on this patient. Here she is post-op. Here is the angiogram, patent bypass, and you can see the bypass here taking over the Sylvian triangle. Another example, posterior circulation from an occipital artery. I have a large number of these dissecting pica aneurysms. Notice the anomaly. Double origin pica comes into one trunk, single trunk, and then very weird. I do not understand why these aneurysms form that way at this location, not at the junction point, but down the trunk of the pica, and then it's growing over time. I did an occipital to pica bypass. There is an occipital artery, like I showed you. I'll show you another more recent case of occipital artery to a P4 bypass. And I am going to show you a 39-year-old man with this aneurysm coiled multiple times elsewhere, and it kept recurring and had a stent and coiled. So here is this. So how am I going to bypass this? Well, I can go to the arrow here, the parieto-occipital artery, P4, not calcarine artery. Calcarine, you will endanger the vision. So how do you do this? You position the patient this way. You use gravity with the lumbar drain to allow that hemisphere to fall, and you will get the occipital artery. Then I'm going to skip through. There is a beautiful occipital artery, excellent flow. Then you do your craniotomy. You go in the interhemispheric fissure. Here is the parieto-occipital artery. If need be, if you're not familiar with this anatomy, you can certainly use the CTA as a navigation to find the parieto-occipital so you don't get lost and go into the calcarine artery. So here we are preparing the recipient. You measure the flow, beautiful occipital artery, in the interhemispheric fissure. And of course, occipital artery, you have to create a channel in the bone, otherwise it will close. And there we are, and doing the anastomosis. Of course, it's deeper, but you can do it with I had to put a retractor to give myself a little more room. And there is the bypass. You see by the curved needle holder, you can suture backwards in a way. And it's all the same. Once you've seen one, you've really seen them all, these anastomoses. And then at the completion, looks good. And the flow at first is 10 cc per minute. Why? Because we have not occluded the PCA. Once we occluded the PCA, the flow in the bypass, of course, went up. And there it is after occluding the PCA, and you will see the patent bypass. Here is the bypass, very nice anastomosis right there, occipital to parieto-occipital artery. Here it is in 3D. So please remember this technique for posterior circulation aneurysms of the PCA territory. There was a small stroke with actually the coiling and the coil occlusion of the PCA that did not result in a significant clinical deficit. Next cell is the in situ bypasses. Let's give you some examples of interior circulation in situ bypass. The most elegant way to do this is excising the aneurysm and doing an end-to-end anastomosis. This is such an example, heavily calcified MCA. I tried to clip it, I couldn't, so I excised the aneurysm. There was enough redundancy, and here is the end-to-end anastomosis. That's the ideal anatomical result when you can do it, when you have enough redundancy in the artery to bring it together. That happens a lot in the pica, particularly, more than the MCA. Remember that the anterior temporal artery is an excellent donor. This is, I used it in this case of a partially thrombosed aneurysm. You can see the partial thrombosis. She had a warning leak and she had a facelift, so she didn't have a good STA. So look at this ugly aneurysm, the base of it. So how am I going to do this? So I'm not going to show you the video, is a bit too long, but you can see the part I want to show you is I had to save these arteries that are stuck on the aneurysm. Please notice the anterior temporal artery. So this is what saved this case. I cut it and I sutured end to side the anterior temporal artery to the M2s. Here is the anastomosis end to side. Then I entered the aneurysm and did the thrombectomy with the CUSA. Here we are entering the aneurysm. Look at the clot. You do a quick thrombectomy with the CUSA. I skipped the part where the CUSA for the thrombus, and now you can clip and detach the neck, and now you can clip the aneurysm. And here we are measuring the flow at the end. So the bypass is filling these branches, and the aneurysm is clipped. And here is a post-op angiogram. Looks excellent, end-to-side anastomosis and the trapped, clipped aneurysm. There was a small stroke, totally silent, no deficit clinically whatsoever. I am going to skip some examples of similar aneurysms without going into their details. An aneurysm like this, what do? You do a side-to-side M2 to M2 bypass before you try to clip the aneurysm. Here is the bypass completed, side-to-side, to give me room to be able to clip this complex aneurysm. And here we are stacking a bunch of clips on the aneurysm. Notice the heavily calcified base, and these numbers indicate the flow. And here is residual aneurysm, which I knew I was leaving because the lenticulostriate arises from it, and it's impossible without losing the lenticulostriate. And this aneurysm did not grow over 7 years of follow-up. Other example is A3 to A3 bypass for a traumatic aneurysm like this. You go the interhemispheric fissure, and this is what I did, and the side-to-side A3 to A3 bypass. How about posterior circulation? As I said, the pica is very important in considering excision of aneurysm. Here is a case. Pica, I could not clip it, heavily calcified, so I excised the aneurysm and performed an end-to-end anastomosis. Or this case, you might look at this second segment pica aneurysm, you might say, well, that's a very easy aneurysm to clip. I thought so before before going into the surgery. Here is the position, far lateral approach, but I want to show you. Oops, sorry. Look at this aneurysm. I tried to clip it. It's 270 degrees around the vessel. Therefore, it's not clippable without leaving a residual. So very simple. Cut the whole artery off and do end-to-end anastomosis, which is what I did here. Another case of a pica aneurysm, end-to-end anastomosis. Here is the occipital artery. I'm doing, oh, I'm sorry, let me show you the aneurysm. Here is the aneurysm. It's a distal pica. So I'm going to skip through some of the details just to show you what it looks like once I'm there. Look at how high the aneurysm. This is a pica. The aneurysm is heavily atherosclerotic. I am trying to clip it, and I'm going to try different clips, curved, so forth. Every time I would clip it, it would close the pica. I put temporary clipping, and look, I'm trying a curved clip, but it's so heavily atherosclerotic. There was no flow in the pica. I tried different maneuvers, and then at the end I said, well, it's not going to work. So what do? You cut it. You just cut it off and do end-to-end anastomosis. And that's what I did. I'm cutting a healthy segment of the artery and end-to-end anastomosis right here. And with the anastomosis, here is the aneurysm excised and the end-to-end anastomosis. And again, looks very good. There we go at the end. And this is another case of subarachnoid hemorrhage. I'm quickly going through it. Look at this ugly aneurysm. You cannot treat this absolutely you cannot treat it endovascularly. It's distal dissecting aneurysm of the pica. You can occlude the pica endovascularly, but that would be a big risk on perforators. Look at this aneurysm. Simple laminectomy because it's low down, and it's a double origin pica. Here is one origin. Here is the other origin. Very strange anomalies, these double origin pica. Here is a clot, measuring the flow. Look at those perforators to the medulla. If you had done this endovascularly, you could end up with a medulla or upper cervical cord infarction. So I didn't show you the aneurysm, but I excised it and I did an end-to-end anastomosis. You can see the double origin here and here of the pica. And here is the completed anastomosis. Post-op angiogram looks excellent. Patient had a very nice recovery. I will skip another pica like this. I did the same thing. I did, in this case, a pica to pica bypass. And again, I'm sorry, just too much material to show you. I will show you another pica to pica bypass very briefly. Here is the aneurysm, cannot be clipped. It's bilobed. Here is the position. But what I want to show you is how it looks at surgery. Far lateral approach, heavily atherosclerotic aneurysm. I tried to clip it, I couldn't. What do? You do pica to pica, right to left, pica to pica bypass, side to side. As I showed you earlier, you have to run the back wall, and then you do the front wall. And when I finish, I trap the aneurysm and trap the pica. So at the end, it looks like this. Bypass completed right here, and the trapped aneurysm. You can see the beautiful view you have with a far lateral approach. And that's a completed angiogram. You can see the typical H of the bypass and the trapped vertebral and pica aneurysm. I will skip this one. I will show, I think if you don't mind, I really want to save time for questions. I'm going to skip to a last case before I come to my conclusions. I believe you can still see me here. Right MCA aneurysm. Look at this, 3 vessels coming out of the aneurysm. There is absolutely no way you can do this endovascularly. I will not show you the video. This is complicated, but I want to show you the schematic of what I did. I took a radial artery. This is 4 anastomoses, and you have to do them in a certain sequence. 1, 2, 3, and 4. The details are not important, but you have to think and strategize all this. And there is no time for the video, but that's what I ended up doing. And this is me analyzing the sequence of bypass. Which artery do I suture first? I don't want to overlap ischemia time for different territories. These are the different ways I could have done it. But what I did is this triple reimplantation technique with the radial artery, because there was no overlap with ischemia. She actually, I made one mistake in this case. One of the 4 bypasses occluded because I chose an atherosclerotic segment. She had a very rough post-operative course. You can see her infarct, but she made a spectacular recovery At 4 months, here she is, 1 year, perfectly fine, having recovered fully. This is my conclusion with bypass surgery. When I teach my residents and fellows, I tell them there are 10 commandments. We're not going to go over them in detail, but you have to select your patient appropriately. You have to be expedient. You have to be proficient. You have to look at the details as well as the whole forest. You have to be meticulous. You have to irrigate with heparinized saline a lot. No clot formation should be allowed. You have to quantify blood flow. I try not to stage it, meaning when I do the bypass, I try to cure the aneurysm at the same setting, the same operation, unless it's not possible for various reasons. We have to keep teaching the young people who are not too familiar with bypasses in the lab or on chicken wings or whatever, on cadaveric, how to do this. And you have to always be ready to break your own rules, be creative, adaptable, and versatile. And this talk isn't meant at all to be against endovascular at all. I embrace endovascular fully, but I want to remind you, as this French author said, tradition's greatest calling is to give progress the courtesy it deserves by allowing it to erupt from tradition, like tradition erupted from progress. Endovascular and bypass surgery and many other things coexist and do coexist and are not enemies of each other. You just have to use your tools differently. And I thank you for your attention, except to tell you that I have started a series of webinars yesterday, actually Thursday, and you are welcome to come to them. They are on vascular and skull base. Here is the link to our neurosurgical website. And yesterday, and these are the series of lectures that are happening every Thursday at 5 p.m. And again, if you're interested in the link, here is the link. It shows you all the details. Next week, for example, we have Charbel and Lawton talking about bypasses. Yesterday, we had Spetzler and Dan Barrow talking about aneurysms, and it's a mixture of vascular and skull-based topics. Thank you very much for your attention. I will stop sharing my screen right now. Thank you.
So thank you very much for such an impressive and wonderful lecture, Dr. Morcos. I'm sure all the audience has learned from your robust experience. So right now we have a few questions from the public. So you don't mind, we can walk on them.
Sure.
So the first one is, what is the best timing to do bypass in ischemic cases?
It depends on is it a TIA versus an infarction? You certainly don't want to do a bypass on an acute infarction, a completed infarction. But repeated TIAs, you certainly can do it at any time. It's difficult. I cannot give a general answer and a certain number, but there is definitely a role for emergency bypass surgery in ongoing ischemia. They are rare, but I've certainly saved many patients doing acute emergency bypass before a completed infarct. It all has to do with the penumbra that you have. But in general, a completed infarction, you wait a few weeks before you do a bypass.
Okay, doctor. The next one is, when do you use saphenous vein versus radial artery for EC-IC?
I prefer generally the radial artery. Well, I prefer the STA to start with. You want to keep it simple. STA, as I showed you, can give you a lot of flow. So you almost always start with the STA. You measure the flow and you decide if the flow deficit you need to fill can be filled by the STA. Use the STA. Otherwise, radial artery. Radial artery is ideal for posterior circulation if occipital artery is not available. The saphenous vein is becoming less and less common, but the saphenous vein is much longer than the radial artery. The radial artery is only about 22, 23 centimeters. So those are the times if you need a long distance, saphenous vein is better, although the occlusion rate of saphenous veins is a little worse than radial artery.
Okay. And next one, if somebody have no TIA or stroke following single attack with carotid occlusion, should we do bypass?
Single attack of, you mean a single TIA or a single what? Or
Yes, somebody who
yeah,
does not have a TIA or stroke following a single attack with carotid occlusion.
no, of course not. You always want to try medically, and therefore you study. I almost never operate a bypass after a single event. You never want to do that. You would be doing the wrong thing. You try medical therapy, maximum medical therapy, and if the patient fails, that's when you do your surgery. I'm sorry, and you also add your physiology. You have to prove through CT perfusion or vasomotor reactivity study with transcranial Doppler or whichever method your hospital has to prove that the patient is in stage 2 ischemia.
Okay, perfect. And next one is, what is your opinion about maxillary artery to MCA bypass?
Yeah, so my opinion is that it is very rare that you need to use it. The reason I say that, and I have this argument with my friends who use it, I'm a skull-based surgeon too. I do lots of skull-based tumors. I'm very familiar with the IMAX. I encounter it all the time when we do tumors here. But the lumen, the diameter of the IMAX is not much larger than the diameter of the STA stump. So you have to always think, is it really necessary? If you can access the STA stump, there is no necessity to go the IMAX. It's nice to have when you have no other options, and it's not difficult at all to get. You just simply go through the middle fossa floor and you do an osteotomy of the zygoma. But what I'm telling you is that it is extremely rare that you really need it.
Okay, thank you. Next one is from Dr. Fahad, and I quote, "Thank you from Senegal. Did the double bypass change the MRS compared to your previous results?"
I don't know that because I have not started. I don't have the data, enough data on the single donor double barrel to compare to previously. That's a very good question, and certainly I'll be looking at that as I accumulate more numbers.
And there's the next one, and I quote, "Sorry, what does it mean, double barrel bypass?"
A good question. Is we have two branches of the STA. Is when you use both branches, one branch on the frontal M4 and one branch on the temporal M4. So you have two pipes going in. Single barrel is when you only use one branch.
Okay. Asa Ali from Brazil says, "Hi, is the one donor to recipient TEQ associated with high risk of ICH?"
Not necessarily. I have, remember, the brain is smarter than us surgeons, meaning the brain will take what it needs. If you put a second bypass and it's not needed, the brain will not take it. It's very different compared to taking a huge saphenous vein or a huge radial artery and dumping very high flow into it. So no, I do not believe the hyperperfusion is more, and it wasn't really more in at least my data.
Okay. Next one. Good evening. How does the conservative treatment be if the patient didn't accept the extracranial intracranial direct bypass in MMD? What would be the drug used? And thank you.
There isn't. There is no medical treatment for Moyamoya disease. There is no controversy in Moyamoya. The controversy of bypass is in atherosclerotic ischemia. The controversy in Moyamoya is whether you do indirect or direct bypass. In children, I didn't cover it very well maybe, but in children, indirect bypass, meaning using muscle or EDAS, is enough in young children. In adults, I don't believe is enough. That could be a little controversial, but nobody is arguing that bypass should not be done in Moyamoya because there is no medical or endovascular treatment for Moyamoya.
Okay, of course. Next one is, how do you store the ESTA or the occipital artery to avoid thrombosis during subarachnoid dissection before the bypass?
What was the first part of the question? How do you what?
How do you store the STA?
How do I'm sorry, I don't understand.
How do you store those arteries in order to avoid thrombosis during?
How do I store? Oh, I see what you mean. Yes, I fill them with heparinized saline with a temporary clip on, and I cover. I wrap the STA in telfa or cottonoid soaking in papaverine, and you make sure it's wet. Make sure the STA is not under the light of the microscope. Cover it, protect it, do your craniotomy, prepare your recipients, and when you're ready to suture, bring in the STA.
Okay. Next one is, are you using pentobarb during the periods of temporary clipping of distal PICA segments during your bypass procedures? And do you use any type of monitoring during this?
I do not use barbiturates because barbiturates, as you know, can cause hypotension. It is extremely rare. I don't think I have a single case where the complication was due to the temporary clipping. The complication is usually due to either thrombosis later or the part of the surgery in case of an aneurysm when you trap the aneurysm or you lose a perforator. So no, on the contrary, I raise the blood pressure during temporary ischemia. And yes, I do monitor, depending where we're doing the bypass, with somatosensory evoke potential or motor evoke potential or brainstem evoke potential, depending where we are.
Okay, wonderful. Could you talk about the learning curve in bypass surgery techniques?
It's an open-ended question. The learning curve, what can I tell you? Yes, of course, it's one of the more difficult skills that we vascular neurosurgeons need to learn. But to tell you the truth, if you have access to as simple as plastic tubes, chicken wings, or of course, cadaveric material, go to the lab. Or at home, bring plastic tubes at home. If you can bring a cheap table-mounted microscope at home and practice as often as you can, anybody can do a bypass. It just requires just practice, honestly. That's all I can say about this question.
Perfect. I quote the next one. Thank you for this amazing lecture, Dr. Morcos. Regarding comorbidities or demographic factors like older age, what are the considerations to select a patient to undergo a bypass? Is there any exclusion criteria?
Yeah, of course. I assume he's asking, I'm not sure if he's asking about, I don't think he's asking about aneurysms, probably he's asking about atherosclerotic ischemia. As you know, those patients often have cardiac morbidity. Absolutely, you have to be so careful, particularly when you have to be very careful in performing bypass surgeries and recommending it because we are on shaky grounds. We have a randomized clinical study, the cost saying bypass surgery doesn't work for ischemia. So you have to be very careful who you choose. And patients, if they are very poor surgical risks, don't do it. Certainly, if you're a young neurosurgeon starting, you certainly don't want to do that. You will have a bad reputation if you have a complication that you're doing unnecessary surgeries. I think it's an operation to be done with a senior partner or by a senior neurosurgeon, particularly because of the controversy.
Okay, doctor. And I'm afraid I will have to
no, I'm sorry, I ran late.
To answer the last one. So for multi-anastomosis, which place would you do in the beginning?
Which anastomosis?
For multi-anastomosis is the question.
Yeah, he probably is asking about that last case that I went over quickly, the MCA. I think that's what he means. It depends on the case. It depends where the aneurysm is. I cannot really answer it without specifics to the patient.
Okay, doctor. And I have an interesting one. So this will be the last one. So what technique do you use for CO2 challenge? DMOX, hyperventilation?
No, hyperventilation and hypoventilation. Our stroke neurologists have a technician that does all these studies across the street from where I am. It's called, I mean, essentially, it's TCD. It's very simple. They make the patient hypoventilate and hyperventilate. Be very careful if patients are very brittle and they have multiple TIAs on a daily basis. Sometimes that can be dangerous. So you have to be careful how you do it.
Okay, doctor. Well, thank you. And on behalf of CN, I'd like to thank you again, Dr. Morcos. This has been a wonderful lecture. We are really grateful and honored for your participation in the 2020 IWBNC. You must know there are more than 3,200 participants registered in this event from over 120 countries from around the globe, and there were more than 400 attendees to your conference in our Zoom live broadcast and other social media. So you are more than welcome to stay tuned to watch more lectures from other speakers. And of course, for all attendees, please stay tuned tomorrow at 10 a.m. Eastern Time for the second Dr. Morcos lecture at 2020 IWBNC. Brainstem carcinomas, concepts, strategies, and technical tips. In a few minutes, we will have Dr. Rokuya Tanikawa doing his lecture, Vascular Reconstructions and Appropriate Approaches for Complex Aneurysms. To get the link for this upcoming conference, please follow the link pinned on the chat screen or check the agenda on our website, cnhood.com. Dr. Morcos, thank you again.
Thank you for everybody for listening. Goodbye.